Ravi Shankar included, is a Bengali,
Yeah,
Yes.
he says it with much authority because his wife is a Bengali.
My wife is Bengali.
Oh, okay. Does she sing or dance or act or?
She sings. She sings.
Yeah. So yes. So everybody kind of one is expected to do, or at
Right.
least paint. I
Right.
mean, we believe that culture makes us better human beings.
Right. So Bengalis are like more with the art, writing, and patriotism. They were all the freedom
Patriotism,
fight.
yes, absolutely. I mean, something that probably links Bengalis to Maharashtrians in a huge way
Is
is
a freedom fight.
patriotism and culture and literature.
Right.
There are states which may be very rich in literature, but they don't have that kind of patriotic fervor.
Right.
Or there may be states which have patriotism, say like Punjab, but then they don't have the cultural leaning. But I think Bengalis and Maharashtrians have that very much in common. But as a race, Bengalis are quite full of life, the
Right.
gregarious. Maharashtrians are more controlled, and they let you be, at least the Punekars.
Right.
So I would say the Punekars are very close compared to a Bengalis hospitality only is compared to the Sikhs.
Right. Punekar is a different type only.
Yeah, that's what people tell me. Don't judge
Maharashtra.
Maharashtrians, but Punekars. But you see, I've had a long stint in Pune, first at the Armed Forces Medical College, where I graduated from, and now last 25 years I'm here. And I was also
Right.
had a stint in military hospital Kharki when I was serving in Army Commission for 3 years. So for me, Pune is kind of quite synonymous to Maharashtra. But whenever I say that, as a race, so they say, no, all of Maharashtra is not Pune,
Yeah. Come to Visai Vira, then you will get a different flavor of Maharashtra. You will
I
like
will.
Maharashtra more.
I told Jayashree this time also that I'm willing to come and do a live talk. She said, no, it's online on Wednesday. Okay,
I will call you online also.
Definitely, ma'am.
I'll come. You all are not too far, so it's doable.
Yeah. Now our recording YouTube has also become live and recording is started.
Yeah, so I had to give permissions for that, so I did that.
So we'll start. Yes.
Okay, we'll start.
Yeah.
Okay. So thank you everyone for joining on this afternoon session for the weekly Wednesday webinars. Today we are really fortunate to get a distinguished speaker like Dr. Barnari Bhattacharya with us. Before going forward, I request everyone to keep their keep their mute button on and unmute only when they want to ask question. But kindly keep your cameras open so that we can see you. And it's always better to see people around while having the webinar on.
Yes.
That's a kind request to everyone, and I know that everyone does that. We are really fortunate to have, as I said, Dr. Barnali Bhattacharya. She is the one who has converted the art of counseling in bronchoastoma in a science into an art. It's more of an art for her, the counseling of bronchoastoma, and she has traveled almost entire India, rural area, urban areas, tertiary care centers. She has worked in everywhere, and whenever we talk about bronchoastoma in children, this Dr. Banali Bhattacharya name comes prominently forward because she has participated in almost everything. She is a core faculty in the Chest Research Foundation, that is CRF, and she has been training pediatricians, chest physicians, even family physicians in the care of the childhood asthma. She is a master trainer of ATM, that is the asthma training module by IAP. She was on the writing committee for the ATM revision 2021, as the review committee for the ATM revision 2020. She has been writing committee under 5 years of WIS, under 5 years WIS 2020. And she is also master trainer for ARCTM, which is the allergic rhinitis and comorbid training module, which is done by IAP. She's a master trainer of RAP also, Rational Antibiotic Practice training module by IAP. and she has been writing committees of IAP consensus statement for the allergic diseases and air pollution in 2020 and 21. And one more thing is that she's the course director of CASPER, that is controlling asthma in pediatric population through education and research. So as you all must have known that her main emphasis is on bronchial asthma, not only on bronchial asthma clinically, but also training as well as the writing modules, as well as the consensus statements and training. So she is really uh, very focused about the training thing. That's why I think we are very fortunate to have you, ma'am. Welcome, madam, to our webinar. We really thank you very much for sparing your valuable time and coming here online.
Thank you so much. And I won't say that, sparing my valuable time. I mean, nothing is of more value than to share, like to quote Tagore, it was his birthday last week, that
Right.
if you have
Pochisha Paisha.
the light, Pochishe Boishak, if you have the light, let others light their candle in it. So
Right.
I think it is, for me, it is very humbling when people call me, and if I can say a yes to it and not make excuses about, like when it was said my grandson was with me, so I kind of dodged Jayashri, and then she gave me this date. I said, yes, I'll be mentally free of family commitments. In fact, my IAP Pune, they postponed the asthma walk, which I had started years back,
Right.
so that I could do it with them today. So it is my ikigai. You know what is ikigai? Ikigai is when your passion, your mission, your profession, your vocation, everything comes together. So, asthma is my mission in life. And I think it is also because my son, who's now 36, used to have really bad asthma when he was 1 year old. And I was then in the Indian Army, and I had gone on a flood relief duty with the troops. And he came down with severe wheeze, and it was frightening for me to see. And when I came back to base, they thought, how people, especially in the last generation, now they value women a little more professionally. At that time, it was that maybe I'm cooking up stories about his being breathless and wanting to come back to base and leave the troops. No, I was not wanting to leave the troops because they belong to the Corps of Engineers. And my husband is a Corps of Engineer officer in the Indian Army. So it was definitely, but we were very fortunate. I went to UK in 3 years' time, and I was in the Great Ormond Street Hospital. And then they asked me, which subspecialty would I like to do my upgrade? So you see, pulmonology those days it still is not a very glamorous subspecialty, right? So everybody would do cardiology, this, that, and then when I said, I'd actually like to zero down on asthma, and so my journey actually started then. So I bought my first peak flow meter 35 years back. So today I would say I'm a baked cake. So I enjoyed sharing more, because now I know I've seen it all. And I've worked in rural Punjab, I've worked in the armed forces. They're all resource crunched, right? And then I worked in Great Ormond Street, and then I've been in Pune now for 25 years. 25 years back, when I came to the city of Pune, the treatment of asthma used to be only nebulization and syrup Ventolin, tablet Visalon, and the smarter doctors gave nebulization. So it has been a very, very uphill task for me. But now people, they are doing things correctly, because it is a disease where you can actually gift a near normal life to a child. And that should be our goal of management. When they come to us, the management goal should not be ki mi tumhala vara karun dete. Because asthma you cannot cure. So I always say, I'll make your child just like any other child, can play, can eat, not miss school, not have the fear of being running to the emergency. So that is what I promise. If you have more expectations from me, then I'm not your doctor. You should choose somebody else.
Yes.
So I think that is it. This
Yes. Very
startup
true, ma'am.
world.
We all are looking forward to learning from you all these things actually. And
Sharing more than you can,
yes,
let it be a two-way thing. I mean, you have so many senior stalwarts, people who are, you can share, issues there. You can ask me about patients that you may be having. So let it be more like a dialogue. That's why I didn't want to do a talk when
right,
Ashley said that, I said, it's so easy for me to put up a slide, share my screen and go on. Afternoon, it's
right.
hot. We've had lunch, I still don't see faces on the screen, but that would make one even more sleepy, isn't it?
Right,
Now
ma'am.
we can do a
And
dialogue.
by the way, madam, you don't look like a mother of 36 years. You're
My daughter is actually 37 and a half. My
wow.
grandson 6 and a half. So
Okay.
that's just I'm blessed with good genes and I do take care of myself. I can't say ये तो ऐसे ही हो गया, but
Yes.
I think I stay away from negative people.
Right, ma'am. I myself am asthmatic and I run marathons and all full marathons. Thanks to
Fantastic. So today, one of the few of the placards. After this, I'll share a PDF with placards that once we use for the walk. Maybe
right.
next year for the asthma walk, you should do that. But my
Okay.
IAP kind of did let me down. I'd given them English and I said, do Marathi translations. No, we walked with English ones. And
Right.
some of the people in the park did say to me, Marathi Madhu, you should have got it.
Got it. Right.
But they stopped and they asked so many questions and me, Marathi Madun, I mean, I just, God knows what I was telling, but they were listening and
Right.
it was, so I'll share that. So one of those was that your child can participate in every game.
Everything. Right,
One
ma'am.
of them is that do not use nebulizers at home, which is something which I hammer everywhere.
Right.
So many patients, so many people actually asked us that, but Dr. Vapartana, then one said that Masa Ghari, like his grandson, 8 mahine ahe wala, and the Balrup Tagnya has given the nebulizer. So I said, you take my picture holding this placard and
Right.
show him when you visit him next time. Ki, te सांगितलं आहे की वापरायचे नाही,
Right.
So we have to be, we owe the society a lot.
So after this talk, our use of nebulizer is going to go down drastically, I suppose.
You must.
Yes, madam. So in office practice, we have these children coming with this ronchi, wheezing, breathlessness, or something, or maybe cough, cold, or something. How to evaluate these children as a case of bronchial asthma? I mean, in office practice, like
Okay, yeah. Let's stick to practical issues.
right,
So basically, as we all know, asthma. What is asthma? It's a chronic disease.
right,
It's a disease of the airways,
right,
and it has reversible obstruction. So
right,
obviously, our symptoms will all be which will be with obstruction.
right,
So it'll be cough, wheeze,
right,
shortness of breath,
right,
breathlessness.
right,
And if it's triggered with a viral URI, and you must remember that viral infection is the commonest trigger in smaller children and
right,
in a little bigger children along with viral URI, it is house dust mite, right?
right.
So there are multiple allergens, but these are the, so when you have a child, so we say a recurrent cold,
Okay,
testy cough, taking long to settle,
right,
meaning more than 10 days.
right,
By recurrent, I mean at least 3 episodes in a year. Now, you might say a child is entitled to have 6 episodes of URI, but a normal URI goes away in 7 days. That's why
right,
we tell people that for 1 athoda, let's wait, because they're so used to people writing antibiotics that they say to me, antibiotic nahi denar ka mala. So I always say, let's hold on for a week. If it goes beyond a week, then we will see what it is. So cough, so the URTIs which are taking long to settle is your first pointer. Second is cough. Whenever a patient comes to me for khokla, I ask them, ki kadi khok do? Is it? So, and when they say ratri, I say ratri manje letne ke baad, in the first part of the night, or is it early morning?
Right.
The first part of the night can be GERD. The
Right.
first part of the night can be, your postnasal drip. Just a plain viral cold can also give you cough on lying down. And then you say, when dhopari zokto khokto ka, they'll say, yeah, dhopari pan khokto. It's then unlikely to be asthma. But if a mother or a father says, 3, 4, 5, subah, then the child coughs, early morning cough, a chesty, dry cough. Remember, a wet cough is hardly ever asthma. A wet cough with a viral infection can. A wet cough in protracted bacterial bronchitis, which I'll touch upon a little later, when only those situations you'll have a wet cough. Otherwise, cough is dry, cough is prolonged, more than 10 days to settle, and cough aggravates on laughing, crying, playing, or the mother says that whenever we go to dhul, or whenever there is smoke, or whenever I'm cooking, there is tadka, the child coughs. So those are all the triggers. A cough with multiple triggers. A cough with just not a viral URI, because then you might say, could this be a wheeze associated viral infection or viral associated wheeze? We nowadays do not use terms like episodic wheeze and multi-trigger wheeze. So if it's a viral associated wheeze, yes, there can be cough, but those will not be aggravated with running, playing, crying. So when this happens now, so we've done 2 things, triggers and cough, recurrence. Now you have to ask, is the child okay in between episodes? They'll say sometimes he's absolutely okay, but when do they come? When the child is not getting well. They'll say, but like from last 1 month, the cough has been there on and on. However, if a mother says ki janma pasun tila khokla hai, darroz khokto, darroz tila dhapeto, that is not asthma.
Right.
Asthma is a chronic diseases with ups and downs, which are related to triggers, and episodes take long to settle. 2 more things which help you in arriving at a clinical diagnosis. One is their family history of allergic disease. Now, something that I've seen in Maharashtra, especially the rural belt, especially the ones who have land, very similar to Punjab and the Hindi-speaking belt, is that they are not very forthcoming with their family history. The moment I said, Tumcha ghari konala, they have decided. I have not completed my sentence. They say, konala nahi, maza ghade nahi. Then the man looks at the woman, and the woman, if her grandmother had asthma, she kind of, looks scared, and it is for me to judge. At this point of time, I say that कोई घर में जब दिवाली की साफ सफाई करते हो ना, तो कोई छींकता है क्या? Because remember, allergic rhinitis is very, very common. And the father, with great pride, they say, "Me cheekto na darroz sakali davela cheekto." Like it is his masculine, feeling like a hero. I say that, oh, to tumcha ghari ko aahe allergy. Then I tell them, I said, see, this is not a blame game. If you do not give me proper history, it is me throwing stone in the dark. I will help you with your child's illness. But if you help me with the diagnosis, I can promise you better treatment, because I know what I'm treating. If I don't know what I'm treating, how am I going to treat your child? And that time they look and they say, Mazi atyala panahe, Ammaza azuba khokto comes. When you let them know that okay, like whether you tell me or not, I know ahe konala, like, you know,
Right.
because then response to bronchodilator. Now this happens with me. It may, because it's a referral center for asthma. I see children from across Maharashtra and from neighboring states. Sadly, they all have been nebulized, and they say, डॉक्टरच्या कडे वाफ घेताना बरा होतो, 2 आठवडे चांगला राहतात, परत होतो तिला. Because then I tell them that nebulizer is a धक्का start. गाड़ी बंद होता है ना, धक्का लगा दिया, चलता है. पर गाड़ी को अगर नहीं ट्रीट करेंगे, उसका क्या कारण है? If we don't find out, then the child, you will keep doing this, and believe you me, the COPD that the adults have, all of them have been childhood asthmatics. It is we pediatricians who are feeding into adult COPD. COPD is a much, much worse disease to have than asthma. You know, they are oxygen dependent later. They are, you know, they even have NIVs at home. They have CPAP machines at home. So it is your and my responsibility to give a good childhood and to preserve the lung function. So what I've told you is clinical diagnosis.
Right.
The other way that you can diagnose objectively, and now every guideline in the world says, before you start asthma treatment, you must find out 2 things. That is there airway obstruction? Is this an obstructive airway disease? And is the obstruction reversible? The reversible airway obstruction is asthma. And this can be found out only by doing spirometry. However, you can do spirometry only in children above the age of 6 years.
6 years.
We attempt at 5 years and we managed to do it. But then it is, you know, it's a skill set that we've developed. But I would definitely recommend that if some of you belong to pool practice, you should invest in a spirometry. You know, we do run courses on spirometry. It's now no more called CRF, it's called CREST, Chest Research and Education and Science Education and Training. And, you know, so those workshops continuously keep happening. As part of Casper clinics also, we do spirometry as a thing. So you should try and do better asthma management by doing spirometry. And your cost of the spirometer gets recovered pretty fast. And, you know, some of the companies are now going to bring a homemade spirometer, which are not even going to cost very much. So it is worthwhile to upgrade your skill so that you can, you know, why am I saying this? That say about 15 years back, I, like all of you probably in this webinar, that in pediatrics, asthma diagnosis is completely clinical and you need a spirometer. And I belonged to this a group of workshop. It was called ROAD, that's roadways and obstructive airway disease, which was for chest physician. And I used to do the talk on pediatric asthma. In that, there was this very senior pulmonologist. Many of you may have known her, the ones who may have been trained in Mumbai. Her name was Jyotsna Joshi. Her name is Jyotsna Joshi. She and Dr. Anjali says Amit could be making a racket. Okay, so but you unmute when you need to ask me something. So what happened? So she would tell me that, and she would do this brilliant talk on spirometry, and I used to look out of the window in my mind and I used to daydream. But she was very fond of me, and so she said that you need to learn spirometry. You need to take it to the pediatricians because you all are missing a lot of asthma. But most importantly, you are labeling a lot of children as asthma who are probably not asthmatics. Everybody who wheezes is not asthma. So with this, I'll tell you story, because I am weaving stories so that it makes it, more like you can relate to. This is about 2 months back. A family took an appointment to come and meet me with their child for asthma, they said, and she was 10 years of age. And when they sat across me, I said that, who has sent you? So they said that our pediatrician has sent us, because what happened, ma'am? Uska naak mein ek polyp tha. So we went to an ENT specialist. He operated for the polyp. And because she used to have noisy breathing and very frequent coughs and cold, he sent us to a chest physician. Now it was COVID time. So the chest physician, this was 2 years back. I mean, they came to me after being with him for 2 years. So I said spirometry kiya. So they said no, but he had put us on inhaler, and which was formoterol budesonide. It was a very earnest kind of a family. They said, "Ami tila darroz dete follow up sati pan jate, but she's not okay." And we just went to a pediatrician once, and she had received 10 rounds of oral steroids. Okay. And we checked the technique, everything was fine. And we did the spirometry, which showed a little bit of a restrictive pattern, but prolonged asthma also kind of, by then the lung functions are affected. So you can have unrestrictive along with obstructive pattern, but she had no reversibility at all. No reversibility. And see how we have become as doctors. I took the history and then I did the spirometry. I hadn't examined her. Then I put the stethoscope and the chest was full of crepitations. Very few rhonchi, but more crepitations. And I was thinking maybe I'm hearing wrong, but her heart sounds are a little more on the right side. And then I said that, so they said, her cough is always wet and she does gad. And I put her on the growth chart and she was about 10 centile for both her height and weight. Then I examined her nicely. And of course, I didn't find no clubbing, but I sent her for an HRCT. And the young radiologist was super excited because he said, and there I wrote, history of operated for nasal polyp, symptoms of allergic rhinitis, also has shortness of breath, wheeze, breathlessness, recurrent, respiratory tract infection, and query dextrocardia. And he said dextrocardia confirmed. And there were, patchy consolidation and collapse in both her lung fields. And that is cartilaginous. So you see, everything is not. So if I didn't do spirometry, what would I have said? I think you're not doing the inhaler correctly. 6 mahine azun deta tila. And then we will. So I put her on long term, clinically, she's very much better. She's also on chest physiotherapy. We've done genetic counseling. But so you see, why I digress is to say that spirometry has its importance. I had another boy who came for a follow-up yesterday. When he came to me about 6 months back with his mother, a single mother, because her husband had died of asthma. But when I did this child's spirometry, it was a small graph, okay? And the graph, so I said, oh my God, this is restrictive lung disease. And God knows what the father had. He probably had some interstitial lung disease and he got treated for asthma and, and he died. And so you then feel very responsible that I shouldn't do anything wrong to this child. But there was reversibility, okay? After I gave the bronchodilator. And yesterday, after 6 months when I did the spirometry, the first, the FVC, which, and was constricted. So it was a small graph. And the FEV1 was also less. But yesterday they were all normal. So obviously there was no reversibility. For 6 months, they've been doing home monitoring of peak flow. But the thing is that, so now, even though in the spirometry it was such a small graph, like I say, a very chronic bad asthmatic can have both restrictive and obstructive pattern, but it was reversible. But I put him on treatment. He symptomatically did well, but children are poor perceivers, right? So as long as they can play, they are okay. But, and I was happy, the mother is happy, because now we know that, yes, the father probably died because of asthma, so it is like that. So why am I sharing all this? Just like all of you, I had a mental block. I said, I can't, why do it? Then once I learned it, I said, God, can I buy one? And will I be able to, get the money back? Like, I mean, to be honest, we are not doing social service, right? I'm not in a salaried job that end of the month. I do need to earn money. I mean, all to, know about it. And I would also think that it would be a good idea if you all belong to group practice, or if you are friends, you should together invest in one, because you will never regret it, never ever regret it.
Right. Thank you, madam. Actually, it's very nice about spirometry. Actually, we have some chest physicians in our area who can do
It's
spirometry
not the
for us.
same. It's not the same,
Okay.
because the pediatric spirometers have an incentive. You see, it is very difficult. What's the cost? Dr. Anjali, the one that I bought was for 70, because I have an inbuilt printer in it. If you just get the pneumotac and you put it with your laptop, and then you get the printer, you can get it for even anything around 35 to 40. But I'm told that Cipla is coming out with its own spirometer. I'm also going to review it to see, does it compare as well. At the moment, it's passed the Tata Memorial Hospital test. Now, that's a very big thing, because they have a lot of lung cancer. They have a lot of pulmonary thing. But yes, it's a good idea, adult chest physician, if you all are not doing. But adult chest physician should not be managing asthma. You should be managing, because adult chest physician tell the patients that they फक्त antibiotic और वाफ देता.
Right.
And so they show you down. So why do that? You can do it yourself, So some
We
of you
treat
can
asthma,
upgrade.
but I was just thinking to send them for spirometry. I mean, or if it is only 35,000-40,000, I think it's quite manageable actually.
Yes, absolutely. Absolutely.
Yeah, Anjali madam wanted to ask something.
Yes, Dr. Anjali, go ahead.
No, I want to pass a comment. It's worthwhile for Amit, because Amit's wife is a pulmonologist.
Your wife is a pulmonologist?
Yes.
You muted.
My wife is a physician. She's not a pulmonologist.
but I think Dr. Anjali has made a fantastic point. Your wife can do the spirometry too. So you should buy a spirometry with an incentive.
Right.
So my spirometer has a hathi, which is putting water in a bowl with goldfish.
Okay.
So I tell them, zorat karaiche, so that the water goes into the thing.
Right,
so you can have incentives into the thing. But if your wife is a physician, I think you should have thought of it before. I think Dr. Anjali is very smart, very smart suggestion. Buy one, and I would have said you can buy the one that I have, the Meyer Spirolab, because they've also done very good after sale service. But I would think the one which is 40K with the thing is also good enough, and you can probably buy the add-on incentive.
Now, madam, you have talked about spirometry. what is the role of peak flow meter or
Good question.
FENO
Good
or
question
chest
and very
X-ray?
well-positioned question.
Mhm.
Peak flow meter is a very good tool. Peak flow meter is actually to monitor improvement.
Right.
Peak
Mhm.
flow meter is not a diagnostic
Diagnostic.
tool. Peak flow meter is not a poor man's spirometer because peak flow meter only measures obstruction in the larger airways. And what is asthma? Asthma is a disease of smaller airways. So you get a basic idea. So can somebody use a peak flow meter when a child has come with a little shortness of breath? Answer is yes. You can do it. And then give them the bronchodilator and see it again. And if you have a 20% increase in your peak flow reading, you are probably dealing with asthma. But the role of peak flow meter in my practice is monitoring. See what happens. You started a patient on treatment, they've trusted you, but you also need to show them objective improvement. A very bad asthmatic, the spirometry is repeated after 2 months. But for the others, it is 6 months initially and then yearly because it is an expensive procedure. It's also time consuming. You can't keep doing it, right? Time consuming to your own clinic. But peak flow meter, my patients have it. I draw a column for them and they do it in the morning before the inhaler and in the evening before the inhaler. Here I would say that I actually have a YouTube channel called Dr. Barnali Bhattacharya. It has a lot of talks on asthma. And on this asthma day, World Asthma Day, I'd actually recorded it before. I just put my own phone and recorded. But because I said my grandson was here and I was not doing anything, social media or working or, he was my priority. But I managed to upload the video on that day. So before I left on a holiday. So please watch the video on peak flow meter because if we keep talking about the peak flowmetry, we will not be able to cover grounds. But that is peak flow meter talk is both for the, our patients as well as pediatricians or doctors who may be listening on. So just put on the YouTube, Dr. Barnali Bhattacharya, and you can see. And a lot of those talks are very useful for patients. So I don't say where I am. I never disclose my clinic. It is not self-promotion at all. It's just promoting the science. But it talks about triggers. It talks about misuse of nebulizer. It talks about role of teachers. Teachers have a huge role in things because they find out that a child is frequently absenting with cold cough. He's not willing to play. When he plays, he coughs. He makes excuses about games because he feels breathless. So if we educate teachers, if you do these talks in schools, you will see there are so many asthmatics who get picked up, so role of teachers, there's a talk. So I think you could probably, all of you, go into that channel and you can subscribe to it so that you're notified whenever I upload new talks.
Sure, ma'am. That's wonderful actually to have this YouTube channel watching.
Yes.
It's a super one. So, do you ever advise anyone to do like this new thing, like exhaled nitric oxide test, or
No.
do you ever do chest X-ray or blood test, or even those allergic
Chest
tests?
X-ray if I am suspecting something else, like in this girl
Right.
with Carter Janners. If I had seen her 2 years back and done a spirometry, maybe I would have done an X-ray chest before I did the HRCT. But because we lost so much time, I went on bang for HRCT. So if it's a small child with recurrent issues, then I might to rule out other diagnosis. See, but not so. Does every asthmatic have an X-ray chest? No. Now you ask me about fractional exhale nitric oxide. No, I don't do it. For a simple reason, it actually tells you that is the inflammation eosinophilic or not.
Right.
Now, we as pediatricians are lucky because 99.9% pediatric asthma is eosinophilic asthma.
Right.
So their pheno is going to be high. Now, I was skimming through the GINA 2022 since I was doing this talk for you all, and I didn't have time, but I said, let me find out if there is anything new that I need to share. So they said that pheno's role, which we always knew, tells you that this child is going to respond to your inhaled corticosteroid because
Okay.
it's eosinophilic. So you're more sure-footed about your treatment. But in pediatrics, they are all eosinophilic, right? Then the other thing is we do not have accepted values in children. So how do you know what is normal and what is abnormal?
Right.
We don't have the values. But if somebody belongs to some high fundu hospital where they do pheno, and then the pheno's role is in adherence.
Okay.
If the child is not taking his inhaled corticosteroids, telling you he's all good, level of control is good, but if his pheno is high, that means there is eosinophilic inflammation ongoing.
Right.
That can only happen if they are not taking. So you can catch non-adherent issues by pheno. But time will say, today I'm telling you this, 5 years down the line, I might start doing pheno because the accepted values will come. Now I already see young adults, children whom I've seen who are 4 or 5, they are now 25, 30. For 10, 15 years, they were okay. Now their asthmas come and they say, we would still like to be treated by you. So, I would probably, then pheno might have a role to know that is this neutrophilic or is this eosinophilic. So what I'm saying today is what we stand today. 5 years down the line, I may sing a different tune. Just the way 15 years back, I sang a different tune about spirometry. And I say, oh, we pediatricians are very bright. We can clinically diagnose. But today I don't say that, So we have to all be willing to grow.
Right.
So I give myself permission to grow. And so today I tell you where Pino's thing is now, but later what it is, we don't.
Right. And what about allergy test, madam, like a skin prick test or the blood test which have come up?
See, like I told you, allergic test has a role when you are not able to achieve control, having done your best, and the technique is right and there is adherence. Do not escalate doses without checking technique and adherence, and comorbids. If your child has allergic rhinitis and you're not addressing the allergic rhinitis and you're escalating your ICS or saying ye bhi nahi ho raha, abhi iska allergic testing karte hain, it's going to be of no use. Now, the allergy testing, sadly, the reagents with which we test are now, earlier they used to come from an international company, they've withdrawn service to India. So now we do not know other reagents completely to be trusted. It is also dependent, and if you're doing allergy testing, it is not that blood test that you do, that in vitro, a whole panel of 100 things, and they will say +1, +2 for every food item. No. Then you can do a panel if you want. Like you can say, I want to do for chana dal. You have a child who's getting besan se allergy, had severe atopic dermatitis because of, besan peat malish, and now this child is asthmatic. That if you're suspecting, say, bronchopulmonary aspergillosis, allergic bronchopulmonary aspergillosis, then you can, before you do the SPT, you can probably do just a serum specific IgE for aspergillus. Okay. But otherwise those tests are of no good. skin prick test is, if you have to do allergic testing, then skin prick test is the gold standard allergy testing, but it has to be done with proper reagents by somebody who can interpret correctly, where you will get no reactions, because you have to do a control too. So the control, you have to be able to do that correctly. And the other thing is that the common allergen remains house dust mite. There are a lot of triggers for which there is no allergy testing, like air pollution, like cloud cover. Is there a allergy testing for it? Your common triggers are strong smell, your viral infection, house dust mite, for which you can do allergy testing. Then your change in weather, strong, your air pollution, smoking, for which emotions, for which there is no allergy testing. So do not have a dependence. But have I done allergy testing? Yes, in a few children whose allergic rhinitis I just could not control. In spite of intranasal steroids, in spite of Montelukast, their asthma got greatly controlled, but that allergic rhinitis didn't get controlled. And the skin prick test was huge wheels for house dust mite. So they were suggested immunotherapy. They took for some time, but you remember immunotherapies for long, for 3 years. It is expensive. So do allergic testing when you also know how to do immunotherapy. I don't know how to do immunotherapy. I don't do immunotherapy. So I don't do allergy testing. I sent it to a setup where they do allergy testing, and they are better equipped to guide them correctly and hopefully honestly, because there's a lot of dishonesty in this allergy segment testing and promises.
So now the diagnosis for the children who are more than 5 years of age is like you're asking for the cough, which is more mainly in the early morning cough, increasing with the exercise, and which is mainly nocturnal, breathlessness, maybe wheezing, and along with you do spirometry and peak flow meter for
Response to
response
bronchodilator.
to bronchodilators, right? So, but what about the smaller children, ma'am, like 1 year old, 2 years old? How
So,
how easy or difficult it is to diagnose a bronchial asthma in these
well,
children?
it remains more of a challenge.
Right.
Younger the child, more of a challenge. So if a child is 6 months and ticking all the boxes, family history of allergy, atopy, response to bronchodilator, frequent infection, frequent chesty coughs and colds, I would, cough increasing on crying, I would be guarded, and I would put on my thing in my prescription. I write very detailed prescription so that if they go to seek a second opinion, before saying take Karunaka, the doctor will read my prescription and either learn a little bit from it, but at least not harm my child by stopping it. So then, say if I have a 6-month-old, so I will say 6-month-old with recurrent episodes of chesty cough responding to bronchodilators, some episodes without fever, family history of asthma present, atopic dermatitis in child, probability of asthma high. This child is being put on trial of inhaled corticosteroids. So I would start this child on inhaled corticosteroid, 100, 1 month puff twice for 3 months, come for regular follow-up, stop it after 3 months. Counsel the parents that if this is asthma, it's going to come back. And if it's not asthma, you might have a very long free spell. So in children under 5, all that I told you about the older children helps. In 2019, GINA's annual manual, it gave us the boxes, which is low probability, medium probability, and high probability. Low probability is cough cold cough less than 10 days, less than 3 episodes, no family history, only triggered with viral infection. Probability is low. Medium probability is that about 10 days. The only thing there is that there is no family history. Okay, but they are responding to bronchodilators and they have other triggers. So in the olden times, this was multi-trigger wheeze and the first was episodic viral wheeze. So you see, they're calling different names, but now it is much better. The first one is low probability, then medium probability, and then high probability. And these are not watertight compounds. A low probability can boom go to your high probability. Okay, he might, like, over time, you will probably delve into the family history. Over time, you will see that this child has started having other triggers. So these are not watertight compartments. And also the impulse oscillometry, we can probably do it in younger children, 3-4 years also. Now you're getting forced oscillometries, which actually shows obstruction. So like you mentioned CRF, and I said now it's CREST. So they have a state-of-art impulse oscillometry, and now they're doing a lot of work on forced oscillometry, and I'm also joined with them. So that's the way that, because force oscillometry is coming, so maybe I can pick up 3 to 4 years old with a clear obstruction, and then, even though Gina still recommends trial of therapy, but I am more sure-footed about knowing as to what I'm treating.
So now we had learnt about that mild intermittent, mild persistent, and severe persistent. Nowadays we are talking about step 1, step 2, step 4, step 5. I mean, how different? I mean, are they the same or are there any differences?
The
Okay.
GINA 2022
Yeah.
released just last week categorically says, please do not use the term mild asthma. If you use the term mild asthma and do not put on inhaled corticosteroids, remember, mild asthma can kill too. 30% of the children admitted with exacerbation are actually so-called mild asthmatics. So do not use your classification of asthma depends on how difficult it is to treat them. Hence, we put them as needing step 3 treatment, step 4 treatment when you first started. Thereafter, when your child comes for follow-up, you will be writing asthma well controlled or partially controlled or uncontrolled. So you will say asthma on step 3 treatment, which can be budesonide 200 BD, or it can be formoterol budesonide 200 BD in an older child, and has remained well controlled. And so you continue the same, and you say technique check found correct, adherence good. So when I have my asthma follow-ups, I write this. Today's peak flow this, child has remained well controlled, adherence good, technique good.
Okay.
And then if they've completed 3 months, I might step down. But if it's impending rains or Diwali coming or Holi coming or Ganpati, where there is again, a lot of dhul, dhua and all that, agarbatti at home, then I wouldn't step down.
Okay. When do you initiate a child on MART? I mean,
MART. Okay. So what is MART?
Maintenance and reliever therapy.
Okay. SMART.
Sorry.
And what is SMART? Earlier it used to be called SMART, right?
Okay.
So the MART word came in GINA 2021.
Right.
And before that, they called it SMART.
SMART.
Meaning single drug for maintenance and reliever therapy. But the company Astra lodged in a legal complaint saying it was not, we coined the term SMART, it was not single, it was Symbicort as maintenance and reliever therapy. Symbicort is formoterol budesonide equivalent. So Gina said, apologies, we will make it maintenance and reliever therapy. So maintenance and reliever therapy is now even cleared for 6 years and above in GINA 2021. Earlier, it was cleared only for 11 years, adolescent and adults. But 2021, they said that we can use it even for children in the 6 to 11 years. So maintenance and reliever, same treatment, but the combination of the drug is not called LABA and ICS. The combination of drug is formoterol and budesonide. Okay, you have to be clear about that. So if you are using, salmeterol and fluticasone as a MART, that is not MART. Why, Amit? Why? Because formoterol has a short, onset of action. Yes, that is why you can use formoterol
as a reliever therapy,
but you cannot use salmeterol as a reliever.
Right.
This is something that we must all know. Sometimes when we go, you see maintenance, that means what she told us is that LABA ICS is a maintenance. No, I'm not saying LABA. I'm saying formoterol and budesonide. Why formoterol? Because the onset of action is short, and in salmeterol, the onset of action is long.
Right.
Now, in GINA 2021, they said there is something called track 1 and track 2. Now, in the chat, can anyone tell me what is track 1 and what is track 2 in GINA 2021? And then I'll pick it from there. You can say in the chat yes or no. If it is no, that means I need to dwell on it. So, Dr. Archana, do you know what is track 1, track 2? No. Dr. Anjali says no. Amit, do you know what's track 1, track 2?
No, ma'am.
Okay, cool. Fine. So let me explain this to you because this is of big importance. This is something that I've incorporated in my own practice in the last 1 year. Earlier, what did we do? Even if we used formoterol and budesonide as our controller, for reliever, we were using either salbutamol or levosalbutamol, right? So we would say, whatever is the brand that you're using, formoterol, budesonide, since it's a thing without any sponsors, I'm not using any, company name of things. So formoterol, budesonide, 200, we would say, ek sakali, ek sandhyakali. And Dr. Jayashree, low dose ICS is reliever? No, Jayashree, I'll come to it. But you are there and yet not there. So 1 and we'd say that if the child has any problem like shortness of breath or cough, then tumitila haraya nila pump, which can be salbutamol or levosalbutamol, don puff char vela vaprache. Now, that has now become track 2. Track 1 is the MART. Track 1 says formoterol on budesonide 1 puff twice. And for reliever also, formoterol and budesonide. What Jayashree said, low dose ICS. So she meant budesonide 100, but no, it has to be formoterol along with it. How can you use a reliever which has no bronchodilator? So the bronchodilator in track 1 is formoterol and budesonide. So the difference between track 1 and track 2 in GINA 2021, which in 2022 says we must continue with it because it reduces the risk of exacerbation, it reduces the risk of hospitalization, it pulls children out faster when they are not children, asthmatics across the thing faster. So if a child is on, so how does my prescription read now? Formoterol, budesonide, 200, 1 puff 2 times. Stroke, I say 2 SOS. And I say, agar iska peak flow has gone less than 80% of the personal best, tumi tila 2 puff deje. If the child has got well, you give 2 puffs through the day. What you must remember, not more than 12 puffs of formoterol budesonide in 24 hours. Why? Because we are only allowed 72 micrograms of formoterol. All formoterol, whether they are 100 or 200, they contain 6 microgram of formoterol. So 6 microgram of formoterol into 12 is 72. So 72 for 11 years and above, and for 6 to 11 years, 48 is the cutoff limit. So that means they are allowed 8 puffs, okay, of total of formoterol. Agar usse kam nahi ho raha, please go to your treating doctor or to the hospital. Is Mart clear?
Yes,
Ladies
ma'am.
and gentlemen?
Yes, ma'am.
Anjali, is that clear now to you?
Yeah. And when do we add LTRA?
Is that clear now? So just remember, track 1 is the MART,
Right.
and MART is formoterol budesonide, and
Right.
you do not need to use a separate salbutamol or levosalbutamol. However, if your patient, ये जीना 2021 के पहले भी हम ठीक करते थे ना, so
Right.
if you have stepped them down and a child is on budesonide 100 11BD, then I would say carry on with the budesonide 100 11BD, and you can use salbutamol or levosalbutamol as reliever. But when I am taking this child off completely on treatment, out of treatment, and this child now is about 8 years of age, then instead of saying agar khokhla hoga, and another thing, ladies and gentlemen, I want all of you to take home this message, that above the age of 5 years, none of the asthmatics can be given salbutamol or levosalbutamol alone without an ICS cover. If you do so, you might trip your child into an acute exacerbation, because there is outpouring of eosinophils during a mild flare-up. You can only block that by giving ICS. The airways get refractory if you keep giving a bronchodilator. They block all the receptors. So if you have, now why am I saying this? Because I have also done this before 2021, right? But when GINA meets, it meets the experts from all over the world. And then it refutes and they say, you know, I lost a child, so-and-so lost a child. So they say that now there is no role of salbutamol or levosalbutamol alone below the age of 5. Below the age of 5, you're okay to use it, because there may be a lot of other where it has wheeze. But if it is an above 5 years, 6 years, you have to use ICS. And if you're using MART, so if it's an 8-year-old and I've taken them off all treatment and now they'll be on SOS at all, that means coming down to step 1 of treatment, then I will get them to buy a formoterol budesonide 100, so that I don't have to say, जितकी वेळा तुम्ही लिव्होसॅल्ब्युटमॉल सॅल्ब्युटमॉल वापरता तिला ब्युटिसाइड पण द्यायचे. It was complicated, right? So now you just say use the formoterol budesonide. Got it? Am I clear on this?
Yes, madam. So you mean to say that ICS, it forms the backbone of the entire
Absolutely.
treatment of the...
ICS is the mainstay of asthma treatment, nothing else. LABA along with ICS is an add-on, not LABA alone. Montelukast.
All the step 1 children, they will be on intermittent formoterol plus budesonide combination.
If they are 6 years and above. If they are 6 years and above. If they are less than that, they would be budesonide as and when levosalbutamol thing in step 1 treatment.
Okay.
And in step 1 and step 2, treatment of 11 years and above, the treatment is formoterol budesonide SOS.
Right.
Okay.
So
So
ICS
today,
is
because the iron is hot, I would just want you to go into Google search and put Gina 2022. You can have a free download of the whole book. And so you can download and think. I always like to read from a hard copy. So I, then give it to one of the printers and they spiral bind it. And there you see, because it'll make more sense after you've been primed that what is track 1 and what is track 2. And okay.
So what I gather from your talk is for more than 6 years old children. For step 1, we give formoterol plus budesonide combination whenever
No.
required,
Six, no,
as and when required.
no. 11 years and beyond is this.
Okay, right.
6 to 11, your treatment is budesonide as and when levosalbutamol or salbutamol. Step 1, step 2. In step 3,
Right.
when you need a formoterol and a budesonide, then you can use a formoterol and budesonide as a reliever.
Okay. Right.
Okay.
Okay. And what about Montelukast? When do you add it?
Montelukast has a very, very insignificant role in my practice. It only has a role when I have bronchial asthma with a very significant allergic rhinitis. Then I will use Montelukast. And if I use Montelukast, I'll use it in the right dose. Till 5 years, your 4 milligram, 5 to 12 years, 5 milligram, beyond 12 years, 10 milligram. And I would at least use it for 3 months before this thing on. Gina 2020 says that now Montelukast should have a black box warning because it does cause irritability and night terrors and neuropsychiatry issues in people who take it. We don't see so many, but now retrospectively, when I see, there are a few patients who did talk about night terrors, but I of course said aise ho hi nahi sakta. But now I accept that it must have been the Montelukast. Montelukast and antihistaminic, please, please, please do not use it. Today, when I was doing the walk, an allergist very proudly said that, my 7-year daughter is so smart that her friend had a rash and she said, Tilam, tu Monterelsi kit ghe. And, I didn't want to tell him anything because there were so many and he's kind of does a fair bit of allergy work. But if you need to give Montelukast, it is for 3 months. Do not use syrup formulation. They're unstable. And do not use in combination because your child will continue taking that whatever. I said Monterelsi because he said, but there are zillions of combination and they will take it for 3 months and it will affect their brain development. You need histamine for brain growth. Okay. And I've had teachers who refer children with drowsiness and because of levocetrazine continuously being taken for 6 months. Okay.
What
So
about
please,
for allergic rhinitis? For allergic rhinitis, giving antihistaminics, do you recommend LTRA for that allergic rhinitis or no
if
LTRA
it is,
even
it,
allergic
it is,
rhinitis?
it is add-on. I
Okay.
don't use Montelukast as first line. My first line would be if it is, you must again see the area guidelines because again, allergic rhinitis is classified into mild and intermittent and persistent. So that depends on the duration. So if it is, somebody comes that, sneezing kabhi iske pehle nahi hua and it's just sneezing now. So I would probably just use an antihistamine, right? And say for 10 days and then bagu apan. But if a patient comes to me and he says that, he has bouts of sneezing every morning, his nose is running, his nose is itchy, and he has that, nasal salute, there is snoring at night, then I would use intranasal steroids. And if there is snoring at night, I might straight on even go on to intranasal steroid as well as Montelukast. But remember something with intranasal steroid, the technique of giving it is very, very important. Many a time, if you do not teach them, like because of a referral practice of asthma and allergic rhinitis, I see most of the referrals are because of uncontrolled asthma or allergic rhinitis, is either the technique is incorrect or or they've missed out on a comorbid. So if you go into the YouTube channel, you will see the technique of the inhalers today. And I think in somewhere I also have a video which I've not uploaded because I had to send it to an outstation patient who had allergic rhinitis, and I got my nurse to do it and send it. Now they take it like a nasal drop. Now nasal drop, you lie down, put your head down and take it. But in allergic rhinitis, you have to sit up, look down, because it's the turbinates that you are spraying. So I tell them that, like this, the pichkari has to go into this things that you can see, those little pearls. If you're going to make him lie down, it will go straight into the thing. So the nasal spray has to be pointing towards the ear, outside, in and out, right? And sitting up, not lying down.
So this clears up the management of children above 6 years. Now, what about the long-term management of smaller children? I mean, as such, the diagnosis becomes difficult.
The diagnosis is a challenge. Acceptance is a challenge. But
yes,
if my thing is that if you are sure what you are dealing with, then you have to communicate with that confidence that, this is it. And with the younger the child, the more be guarded. If a child is young and has had symptoms from birth, unlikely to be asthma. If a child is hypoxic, disproportionate to the asthma symptoms, unlikely to be asthma. If a child has gas, vomiting, significant, then it is unlikely to be asthma. If a child has stridor and not wheezed, it's actually malacia, then it is not asthma. But if your probability of asthma is high, then it is asthma. But in under 5, you have to first give them a trial of therapy for 3 months, stop it. If it trips again, then label it as asthma and treat it as asthma. So when they say for how long, I say a minimum of 6 months, a minimum of a year, because then if I start 200 BD, then I would bring it down to 100 BD, then I would bring it down to 100 OD. And if it's every 3 months, and I would think it will take anything about a year, and then they might say ki aadat padnar ka tila, then I will say te brush karto ka tumcha bal. Aadat zala ka tila, that is a good habit, right? So everything that you do daily is not bad. And then I say that, see, I am old, so I am using glasses, but Amit across me is a young man. So if I have a young father or mother with spectacles, I say, te tumcha aadat ahe ka chashmya ka. You need it, right? With the chashma, you can do everything. So similarly, your child just needs the inhaler. So you have to counsel depending on the family that is sitting across you. You cannot use the same language for everybody. To a savvy family across me, I can say if you don't do it correctly, they'll be remodeling and we'll have loss of lung function. And to a gaon ka aji, I'll say aji darwaila तुम्ही तिला वाफ देता, like गलीचे डॉक्टर करून, या तुमच्या घरी पण आहे. See, I have a sari. अगर एक जगह फट गया, I will stitch it and I'll wear it. But every time you're doing this, it is like the sari tearing. अगर 10 जगह ऐसे होगा, तो you will say, ma'am, कि तो बहुत बुरे दिन हो गए, फटा हुआ साड़ी she is wearing. That is the way your child's airway is going to become. So use a language that they understand, have multiple ways of explaining, but remember something, that if you counsel them well about accepting the diagnosis and agreeing to the inhaler, adherence bhi ho jata hai, avoidance of trigger bhi ho jata hai, you know how to. So I do a talk on 5 A's in asthma counseling. Some of you may have heard it. It is helping them in accepting the diagnosis, A for acceptance, then get them to agree to the treatments that you planned for them, then make them aware of the triggers and avoidance of triggers, it's called A for avoidance of triggers. Fourth is adherence. They have to adhere. When they come to me and they say, so and so has sent because आपने उसको ठीक कर दिया, ऐसे उसको ठीक किया मैंने नहीं, उसको ठीक किया my buddhi, but their parents, because they've given it every day. So if you are willing to do what they have done, your bacha will also get okay. Adherence. And last is to be aware of acute flare-up and how to manage it at home. So 5 things you have to do when you do asthma counseling. But you have to do, one of my mothers said that, I am now sure-footed because you made me button the shirt of my child well. Because if I put the first button in place, sab button jagah mein girenge. But if you are going to prescribe them inhalers and the chemist there is going to explain the inhaler, they will not do it correctly. They'll stop coming to you. The child will land up in an ICU with a flare up, and you will become badnaam. They'll say ki usne to kuch nahi kiya, 1,000 rupees ka dawai kharidwa diya. So you have to be true to it because it's very gratifying, because you're actually turning around the life not of a child but of a whole family. Because the parents can't sleep, because the child is coughing at night, the child can't go to school. So the mother and father, somebody has to take chutti and be at home. The child cannot play, the child cannot have ice cream. So there are so you can do so much if you do asthma well.
Madam, how do you really manage these small children? I mean, for a long term, do they manage same as like more than 6 years, like you gave ICS?
So the under 5, I do not use LABA for them. Under 5, I will use inhaled corticosteroids. If the child is less than 3.5 or 4, my device is going to be different. My device is going to be a spacer with a mask. The spacers that I choose always have to have valve. A valve is of utmost importance in a spacer. So do not just pick up a spacer which you can see through and through. It should have a valve. And then, but if a child is 5 years, then do not use a spacer because you're increasing the dead space. So it is important to know what device to use. Use inhaler for them. Do not use DPI or a breath actuated inhaler for them. And the drug for them remains budesonide. You can also use fluticasone, but fluticasone is not available in the entire formulation. We do not have 50. So, but in budesonide, you have 200, you have 100. So you can go down to 100 OD. So if a small child, I would start with 200, 1 puff twice, and continue with salbutamol or levosalbutamol as reliever. And I will write my asthma action plan is written that if this happens, then you have to start giving two puffs, 4 times. If it is, if the episode is, breathlessness is more and the child is not speaking in sentences, then you can give 6 puffs back to back. And now, of course, everybody has pulse ox at home, so they can also monitor like that. So after the child is well controlled in 200, 1 twice for 3 months, then I would bring it down to Budecort 100, 1 puff twice for 3 months. If the child is well, then I would bring it down to Budecort, budesonide 100, 1 puff at night. So that's the way to do for a younger child who has high probability of asthma, whom I have labeled as asthma and I have documented it in the paper as to why. So I tell the parents, I'm ticking all the boxes. So you should learn to write those boxes and tick it. So if your patient is unhappy with you and says, oh, Dr. Amit has started, my child on inhaler, and say goes to Dr. Anjali, and she sees that you have documented why. So she would say that, he has done right. And then it is the patient's choice. Might stay with you, come back to you, or might choose to be with her because she has probably given him more time. Why did your patient leave you in the first place? Because you did not give the child time. You wrote inhaler, written the boxes. You've theoretically done very well, but you've not told them why. So says, okay, let us go to another doctor, chooses Dr. Anjali. And she says, oh, Amit has done everything right. Why has this happened? Then she counsels them a little bit more. No, tila, te paije, te barobar ahe, tumi tila ghe. So they said, oh, madam, ghe na tumchakade yeuka. She has every right to say yes then. Yes, like that.
And what about
Sometimes they
nebulization?
go back to the doctor who suggested. That is the right thing to do.
Yes. So, like, what about the nebulization? The first time visa has come about 2 years.
Okay, now I think we have 5 minutes more, and I
Okay.
am only going to talk about nebulizer, and then we will probably see if there are any questions and
Right.
then bring it to a close. Ladies and gentlemen, nebulizers are used to deliver reliever drugs. Nebulizers deliver drug in a lot into the oropharynx, a lot into the atmosphere. The amount of drug that reaches the airway into the alveoli is much more with an MDI and spacer than by a nebulizer. They have tagged the drugs and they've done centigrams, and they have found that the drug of a 2.5 milligram of salbutamol versus a 200 microgram of salbutamol, the amount of salbutamol in the lower airway is much more with a spacer and MDI. Second, you have deposited 1.5 milligram of salbutamol into the oropharynx, which is going to go into the systemic circulation. So if the child is nebulizing and nebulizing and nebulizing, you have the risk of giving this child palpitation, irritability, you have hypokalemia, and if this child is hypoxic and they are just doing this, then this child can have a VQ mismatch and land into catastrophe and die. 3, nebulizers, especially when they have at home, they do not clean. So the nebulizers can grow fungus and or have other bugs. Your child with pure asthma can land up with pneumonia, with weird organisms, including fungal pneumonia, and succumb to fungal pneumonia and die. So if your reliever drug has to be given, it has to be given with the MD and spacer, not only at home, even in your clinics. What all of you do wrong is that you use the nebulizer. Tila vav de sister, vav deun thaka, tab tak main 5-4 patient dekh lu. Wrong. You are doing cross infection. This kid could be COVID. Yes, the COVID bug is all over. Your nurse will get infected because she's giving it. The bugs are all over because there is a lot of respiratory which is generated when we are using a nebulizer. The other thing is that you are also probably not cleaning your nebulizer as you should be end of every day. I'm being honest. So should I not use a nebulizer, ma'am, at all? Yes, you can. If you see that the saturation is less than 94, if you see that your child is getting drowsy, not talking in sentences, refusing to accept feeds, if you're in a hospital setup, before you're telling them to get a bed ready in the ICU, you will nebulize with oxygen. In an acute severe asthma, what is the drug of choice? Oxygen. What is the second drug of choice? Inhaled bronchodilator, salbutamol. What is the third drug of choice? Steroids, which can be oral or injectable. What is the fourth drug of choice? Ipratropium. 95% of your acute severe asthma gets managed with only this. But in our panic, we are not doing the oxygen. So your nebulizer then should be on an O2 drive. Why do your patient use nebulizer? Because they see that every time the child comes to with breathlessness, they sir, they madam, they vapur, they barobar ho jata. One patient today in Sarasbag told me that dar bar me vapasati gyun jate balala, that doctor charges 300 rupees. Sakali dupari sandhyakali 300 dete, to the pharmacist said, माझ्याकडे घेऊन जा. Who started the spiral? We, right? So stop it. Do not use nebulizer. Use it when your child is hypoxic and you need to deliver the salbutamol with the oxygen. Please, please, please do not prescribe any nebulizer at home, because you are doing great harm to the society and community. Okay? Fine.
We would have loved to.
Are non-pharmacological mental breathing exercise? Yes, they are. But they do not treat asthma, but they are an excellent add-on. Now there is a lot of work that's happening. Actually, Dr. Alpa Dalal, who is in Mumbai, she's a chest physician, and she's also a yoga instructor, and she's doing a lot of work in it. And yes, definitely. But if somebody says that my child's asthma has got well only by doing pranayam, I won't believe. Probably it wasn't asthma, or has gone into the phase of remission and might come back again. So I said, Changla, so if somebody says, can I try a homeopathy and Ayurvedic with your treatment, ma'am? So I say, एक करते हैं, तुम्ही पहले उनके पास चले जाओ. अगर वो ठीक हो जाता है, very good. You don't need to come back to me. But along with me, you will not do this, because मैं अपने पैथी का credit उनको नहीं देने वाली. So you can do that. I will wait. No problem. But so many a time they say, we heard, you better do it. And many a time they've already done homeopathy. I see so many homeopath kids who landed to me after their ICU stay. So I use them to do talks so that, the community understands that, the little white pills are not as harmless as they appear to be. At least as we know what we are giving, the patient knows what drug I'm giving. He can see what is there in my formulation. If they ask me, is there steroid? I said, yes, there is steroid. But this is the same that will be given to your child if I'm working in the best hospital in USA and UK. So don't think that because we are a poor country, your child is being given harmful medicine. There also the treatment is the same. Okay.
We would have loved to go to the exacerbation of bronchial asthma, but that's a very big topic. I think we should stop over here.
We should control asthma such that we
should not be any exacerbation. Right.
And I told you.
One question, can I ask?
Yes, sure.
Yes.
Yeah, this year the theme is closing the gaps. So it's only the awareness which is the gap which is there, or you want to add some more things?
Closing the gap is between you and the community, between somebody who knows a little more than somebody who knows a little less. Today is a closing the gap, right? Because we covered stuff which was there in GINA 2021, and it is absolutely okay to not know. Do I know about other diseases? No, I don't know. So it is because it is my ikigai. So I, and that is why I enjoyed sharing it. So we've closed the gap. I did 2 closing the gap today by my asthma awareness walk and by meeting all of you.
Thank you.
Anyone else has any question? Please raise your hand so that we can ask those questions to ma'am. I think ma'am has made these things very simple
I'm
for
taking
us.
a picture of this.
Okay. Anyone has any question?
Thank you very much. Any questions? There's something in the chat. Wait, let me just check the chat. Clear. Can your 5-year-old high probability asthma with AD is attention deficit? Dr. Gandhali?
Atopic dermatitis, ma'am.
Okay, with atopic dermatitis. So this would be the same as you're managing the asthma, and you would also simultaneously treat the atopic dermatitis with, a good emollient and also a good steroid on the skin. And remember that they would do it for 5 days, 7 days, and then stop it. So you have to say that the so I write emollient continue, just the way I put my ICS. And then I say, this is the steroidal thing. Give it for 2 weeks. Let's see the follow-up. Sometimes you need to give maybe OD dose for even good, a month or 6 weeks too. So atopic dermatitis can be very difficult, but a 5-year-old is on the thing of going on. Okay, Dr. Kohili's batchmate from. Okay. Oh, hi, Gandhali.
Hello, hello.
Can I see you? Can you switch on your video?
Yes, ma'am. Yes, ma'am.
So atopic dermatitis, you have to treat atopic dermatitis, but you must know something. Children of asthma who kind of take their asthma into adulthood, atopic dermatitis is one of those poor markers. So when I have a child whose both parents are asthma, and the child has atopic dermatitis, and the child is presented early, this is a child who probably is going to, even if goes into remission, might again come out as an adult asthmatic. So nice to meet you.
Anjali ma'am
Kuhili
wanted
is
to
my daughter, who is Gandhali's classmate. So good, second generation attending.
One last question, only one.
Yes, sure.
We have
What
seen
about mosquito repellents? That's a great question. So mosquito repellent, the kachua chop is equivalent to 100 cigarette smokes. So never ever use a kachua chop. And if you're going to do, see, you have to choose between two evils, right? Do you want to get dengue or do you want to get a mild flare-up? So I would say a mild flare-up, which I can manage, is safer than getting dengue. So then I would say use the repellent, but put it away from the child's face in the bed. But best is to use mosquito nets.
Madam, we have seen children with more than 5 years also has a difficulty in taking inhalers, and sometimes we have to give spacer. So is it right or is it wrong? Because they find it very difficult to take directly. They cannot synchronize between the pumping and inhalation.
No, but you don't have to synchronize, Dr. Barot, between, if you're using the spacer cuts away the problem of synchronizing. Okay. So when we are, now let me go over this with you. When we have a small child and we use a mask, we say, I would also want you to see my technique of inhaler in the YouTube. So you will see less than 4 years who are on the mask, you say keep it for a minute, sitting. The ones who are with the spacer, okay, no child should be without spacer at all, ever. If you and me also need inhaler, it has to be with spacer. The word synchronization comes only if you are doing it without the spacer. So if your child is with the spacer, he holds it tight in the mouth, you shake it and you put it, so they can take up to 6 to 10 breaths. Okay? Like that. However, you might have a child with a lower understanding. We do have children with attention deficit. That's why I asked her that by AD, do you mean attention deficit or ADHD children who cannot do it like the way you say, that, is just not able to breathe from the mouthpiece of the spacer. Then you can probably prolong using the mask for a little while long, but communicate with the parents that this is not the ideal way. They should try and teach the child with just the spacer and the inhaler.
So spacer is a must, right?
Spacer is a must. You can never use an inhaler.
No mask after 4 years.
Pardon
No
me?
mask after 4 years.
No mask after 4 years.
Spacer
Spacer
is a must.
lifelong.
Lifelong.
Spacer is lifelong. Even if I need it, or say my son might need an occasional formoterol budesonide, the choice for him is two. One is a spacer with formoterol budesonide or a breath actuated inhaler, which is as good as a spacer with the inhaler. So a lot of adolescent, I use a BAI, which is a little expensive, but that the delivery is as much as the spacer with inhaler. Remember something, if you're using the inhaler alone without the spacer, only 1% of drug comes into the lower airways. Okay, so never should you use it without the spacer. That
One
was a
last
very
thing.
good question, and I'm so happy that you asked it.
So
Because
one
many-
last question. One
Yes, go
last
ahead.
question.
Yeah, go ahead.
You said that you have to use spacer with the valve.
Yes,
right?
yes,
A small kid, 6 months to 1 year, who has very poor inspiratory drive, and most of the time when we put them in a supine position, almost the valves are closed and they cannot breathe properly because their inspiratory drive is very poor.
Okay.
So till now we were giving them a spacer without valve till the age of 1.5 years, and after 1.5 2 years we were giving them spacer with valve when they sit up, or when they sit up and take your MDIs.
okay.
So any comments on that?
Yes, yes. Firstly, you said supine, your child should never be supine.
6 months old child, 8 months old child who are
6-month-old child should be supported on the mother's lap. The child should be sitting. A 6-month-old child sits with support. So a 6-month-old child should be on the mother's lap, head resting on her chest. Okay, 2 people need to do it. The mother can hold, put the legs in between her legs and hold the head and thing, and somebody else does that. So never should you give inhaler to a sleeping or a supine child. And the tidal volume that opens that valve is a 6-month-old child's weight would be 6
6
kg.
years, 5 kgs, 6
Yeah.
kgs. Yeah.
So your 3 ml per kg is the tidal volume.
Absolutely.
So 3 into 6 is 18.
Yeah.
Right? And it takes just 10 ml of tidal volume to open the valve. Okay, so you can use the same valve, and do not fall into the trap of a small spacer. That small spacer has a much tighter valve. So use the 200 ml spacer with a valve. And if you feel that your child is not able to open the valve and the tick tick sound you cannot hear, then you just tilt it a little bit, just to give the child, instead of putting the child flat and closing, you hold your child up on sitting, and when you're holding it, just tilt it a little bit and it will open easier. Okay,
Thank you so much, ma'am.
you're
Thank you so
most
much.
welcome. Okay.
Okay. Thank you very much, madam, for the valuable inputs. It's too late. I think it's 5:15 almost. And
I
the
must
time
go
has
because
flown.
I am seeing missed calls from my nurse. That means she
Okay.
must be saying that it's time for you to come to work. But that's okay. That's okay. We don't do this every day. So I didn't want to rush you all at all. And I've enjoyed doing it. And I hope I have made a difference and we've closed some gaps.
Absolutely.
Thank you so much. Thank
Yeah,
you so
it was-
much.
Thank you very much for having me and inviting me. Jayashree, thank you very much.
Thank you, madam, for
for,
coming
and,
online, and we
Dr.
want to learn more from you.
I'll
We
surely
want to
come
learn
sometime.
more from you. Yeah.
Sure.
Yeah.
Bye.
We'll have
Thank you.
Hi, madam.
Asthma training module with madam sometime
Yes,
for our
live
class.
module will be better.
Yes, we can do asthma training module. I can do Casper, which
Casper
is
also,
which is
yeah.
probably even may make it is. I would say it is. They're both very good modules, and I'm the writing for both, so they're both my babies. But so anything that you wish to, we can do it for you. Okay.
Thank you.
Bye.
ma'am.
Thank you, madam. Thank you very much, ma'am.
Bye, everyone. Thank
Thank
you for having me. I'll leave the meeting now.
Thank you.
Thank you, ma'am. Thank you very much for spending your valuable time.
Thank you.
Thank you everyone for joining this meet and joining on this great learning curve. I hope everyone has learned a lot from this talk.
Thank you, Amit.
Thank you,
Nice
Amit. Good
Dr.
moderation.
Saman.
Thank
Good
you,
Yeah.
Amit.
moderation.
You always study and do moderate. That is good.
Thank
Yeah.
you, Deshpande madam, for
Arey,
bringing
thank you.
such lovely
Oh.
speakers.
Very, she is a visual treat also. When she
Yeah.
talks also, she's
Proper
dancing only.
Bengali. Bengali.
Bengali, yeah.
So we should have her once for 8.
Yeah, once for
Sama
she's
meeting.
ready actually. She was ready for a live meeting. पण आम्ही म्हटलं की आधी आम्ही ऑनलाईन घेतो आणि then we can ask Sipla people actually will ask like they sponsor her. So they
Actually,
were
we can have
ready.
one day workshop, madam, because it's
One day
a
They were
lot.
workshop.
ready for a
One day workshop.
sponsorship also.
We
Sipla
haven't
पण मला
touched
फोन आला.
even 30% of the asthma management. It's a lot to cover. It takes a lot of time actually.
And
Yeah.
new guidelines track 1 and track 2 वेगळ्या आहेत बऱ्याच.
ठीक आहे, चालेल.
Okay, thank you.
After
Thank
we
you.
finish with our ECD and our breastfeeding, then we'll get some time for asthma. And I appeal to all of you, please join tomorrow's meeting.
Yes.
Tomorrow, 3 o'clock, everybody should be there for the breastfeeding meet, which we have organized. The Palghar Academy of Pediatrics is organized.
And please send nurses to Dr.
Nurses
Vikas
week.
Hospital for a self-defense training.
Yeah.
On
We are
nurses
sending
should
7.
be there.
We are sending 7.
Dr. Saman, Palwankar madam, तुम्ही पाठवा अनु.